Hello and welcome to the channel. This is the second video for the clinical pathology portion of the Part 1 NBCE chiropractic board exams. This program I've been developing for the past couple of months, and it is designed to help students pass Part 1 the very first time that you take it. The first handful of videos are going to be made public, as well as they're public in a couple of the other playlists that I have down below for the other topics. If you're interested in getting full access to this program, go ahead and follow the instructions down below and enjoy the material and have a good day. Inflammation and repair is the next chunk that we're going to talk about. There's not a ton of questions that comes from this whole chunk, but the questions that you will get are pretty specific to it all. As well as this whole little chunk is also going to give us a lot of information and some specific insights into what we're going to see in other regions and other topics. So with general concepts of the inflammation, this is the body's protective response to injury, infection, irritation, any type of cellular damage. We have immune cells, blood vessels, and then mediators as well. We're going to focus more on the immune cells and then the molecular mediators, and also kind of the general signs, symptoms of inflammation, as well as the stages or the steps of inflammation. So some of the big signs, what we want to look for with inflammation, with any type of injury, is rubor, color, tumor, dolor, and functio lesa. So the meaning of these, oftentimes the questions that they're going to ask on part 1 is something along the lines of which of the following is or is not a sign of inflammation. And they'll use these more Latin root instead of the actual meaning of them. And as well as they might ask you to define some of these. So they might ask you, according to the signs of inflammation, what is tumor? Tumor is swelling. Or they could reverse it. Which of the following is the sign of inflammation for redness? And that's rubor. So understanding those, just knowing the names specifically as well as what they mean, good for potential test questions. Now we break inflammation into acute versus chronic. Most of the stuff that we're going to talk about is more of the acute inflammation, as that's typically what we deal more with, as well as it has a specific and defined process. So there are 7 steps to acute inflammation. We get the injury, and that tissue is damaged, and we get an immune response that is triggered. Immediately, we get vasoconstriction. This is because when we have some type of wound, we have a sympathetic reaction as well as the endothelial cells release what is called endothelin 1. When endothelial cells are injured, they release this specific endothelin 1, which actually causes vasoconstriction to ensure that we don't lose any blood, or we don't lose too much blood. After that, once we're set, that we know that we're not going to have massive blood loss, all this stuff going all over the place, we actually get vasodilation to the area. And this is because we need to bring a bunch of our immune system cells into the area to start cleaning stuff up. And also we want to do, we actually want a little bit of swelling, or the body wants to do a little bit of swelling to kind of lock into place that area, prevent it from moving, and make sure that it can heal properly. We have histamine, bradykinin, as well as prostaglandins. These are ones that are released in the specific area. Like bradykinin, for example, is also created when we have endothelial cell damage. Histamine and prostaglandins are produced, again, in that same area when we trigger inflammation. The vasodilation, this is where we get the redness, the rubor, as well as some of the warmth, the heat, the color as well. With the vasodilation, all of the blood rushing to the area, we also get increased permeability. What this is saying is because we have vasodilation, the pressure of the blood. More blood flow means greater pressure, specifically greater hydrostatic pressure. And that is actually going to force more fluid, more nutrients, more of those immune cells out of the blood vessel and into the surrounding tissue. And that is where the swelling and the edema come from. That results in the swelling, the tumor, the pain, the dolor, and then also that functiolesa, that loss of function. Next comes the cellular response. The very first immune cell response in pretty much everything is going to be neutrophils. So any type of question that you get about acute inflammation within the first, like immediately after the event, we always say neutrophils go up because they're going to be accumulating at that site of the injury. With the cellular response, we also get chemotaxis. Chemotaxis, this is the mediation, like mediator factors are going to signal the different cells to come and migrate to this specific area, especially the macrophage cells. Those are the phagocytic cells, the ones that are going to come in and kind of eat up and break down all of the damaged tissue. It triggers diapedesis. Diapedesis is this process of the cells going from the bloodstream, getting closer to the endothelial wall. Then they actually do a little rolling along it until they match up and bind and adhere, and then do diapedesis, which is the immune cells passing through the endothelial wall into this space to go and do the phagocytosis. Phagocytosis is actually that next step, removing the pathogens, debris, and damaged tissue. And then we get healing, resolution of it. We repair or replace the damaged tissue, and we're done with inflammation. Or we can move on into chronic type situations where we end up having recurring and constant inflammation for long periods of time, which we'll talk about that again in a little bit. This is the process of diapedesis, how it happens. We get margination first. White blood cells actually move towards the walls. They roll along, then they adhere. After adhesion, they do the diapedesis and come through. They follow the chemicals that are being given off by the damaged tissues and the other mediators to then go and start munching and breaking down the pathogens, the damaged tissue, whatever else is going on there, getting all the stuff that shouldn't be there. For chronic conditions, chronic inflammation, this is persistent inflammation. So it depends on which textbook you specifically read. The generally accepted term is that after 3 months, it is officially a chronic condition. I'm not 100% sure which specific textbook boards likes. Some specifically say that for conditions, it's more like 21 days or 3 weeks. Others say all the way up to 3 months. I believe the most accepted is 3 months. After the 3-month mark, that is when we officially determine a condition to be chronic. When we talk about chronic inflammation, we also want to talk about a specific type of chronic inflammation that is called granulomatous inflammation. This is a type of inflammation where we get clumping of a bunch of different immune cells, of the granular cells that are involved in the immune system. And we get these balls, we call them granulomas, these groupings of all these chunks because of the constant production of the immune cells trying to fight off the infection or whatever it is that's going on. The two most common places that we see that is with tuberculosis, which causes a caseating granuloma. That's that caseous necrosis, that cheese-like necrosis. We call those Ghosn lesions, as well as sarcoidosis is another common one. We call those non-caseating granulomas. Those are the two big ones that they, if they're going to ask you a question about granulomatous inflammation, those are the two specific ones they're going to ask about. Okay, and that's really all there is to chronic inflammation, just knowing the timeline. The last other bit is we also get more lymphocyte involvement. Instead of just the neutrophils, we can have an uptick and a spike in other of our white blood cells. So just pay attention to the timeline of an injury when you get asked specific questions. Now, when we talk about wound healing and repair, these are just the three basic phases of wound healing. We have our inflammation, then we go into proliferation. We get fibroblasts coming back to the area of the damaged tissue. They deposit collagen. We also get angiogenesis, new blood, and everything moving back into the area. And finally, remodeling. That's where we get the scar tissue officially forming. The type 3 collagen that the fibroblasts laid down converts to the tougher, denser type 1 collagen in order to protect that whole area. So if you want to spend a little bit of time looking at this picture and understanding that process, that's fine. The big things that they will ask about is the type 3 to type 1 collagen conversion, as well as just the order of it. It goes from inflammation to proliferation and then finally to remodeling. A little bit more about collagen, mostly just understanding the types of collagen, what they're good for, and then the most common locations for them. Type 1 collagen, this is our most abundant collagen. It is everywhere. It is our tensile strength collagen, bone, skin, tendons, muscles, ligaments, fascia. Most of our collagen is type 1 collagen. If you are ever looking at a question and it's asking you about identifying the specific type of collagen, your best guess is to guess type 1 collagen because it is the most common if you have no clue what the answer is. But type 2, 3, and 4 are found in very specific spots. So it's easier to remember where these are located, and then anything else we pick type 1. Type 2 collagen, it is our hyaline cartilage as well as our elastic cartilage. It does a really, really good job providing resistance to pressure, so like squishing pressure. It is found in the intervertebral disc, specifically the nucleus pulposus. This is highlighted because anything that has to do with the spine, this can pop up in pathology, general anatomy, spinal anatomy, physiology, a little bit of everything. Okay, so anytime it involves the spine, we flag that and make sure that we 100% want to know that because that can be tested in all of the different areas of the exam. Type 3 collagen is known as the reticular collagen, and it is seen in that early wound healing. We see that it gets converted to that type 1 collagen after it's been processed and put into where it needs to be. And it's in the blood vessels, lymph tissue, and the bone marrow. Type 4 collagen, nothing too crazy. It's found in basement membranes, specifically epithelial cells, and also the kidney. Here I have just some images of each of those. Now, where we really get into some of the stuff that can get us into trouble with this exam is with all of the different inflammatory components. And a lot of this is just going to be word recognition. It's going to be understanding definitions. and then understanding where these are seen, especially when we talk about conditions of patients. So, for example, neutrophils. We mentioned this previously, how with acute inflammation, neutrophils are the first ones to pop up. Anytime we see a patient, anytime we have a question that specifically states that neutrophils are high, we did lab work, neutrophils are high. Either we have immediately we know this is an acute condition. This is not a long-term thing. This is a recent condition. Either it's going to be a bacterial infection or acute inflammation, and it would have to describe some type of specific injury. Okay, so if we see neutrophils are high, immediately we say this is a bacterial infection. Along with that, anytime we have a bacterial infection, we're also going to have a fever, at least 99.5 degrees Fahrenheit or higher. Typically, good rule of thumb is to say if it's not over 100 degrees, it's probably not a fever. Lymphocytes, these are part of our adaptive immunity, which means that they learn, they respond, they store the antibodies, and they learn and they know and they grow. These are going to be with viral infection as well as chronic inflammation. Think about chronic inflammatory conditions like rheumatoid arthritis, lupus, anything that has to do autoimmune condition, Hashimoto's thyroiditis. Those types of conditions, we have lymphocyte involvement. Some type of virus or chronic long-standing inflammation, the lymphocytes get involved. There's three main types of lymphocytes. We have B lymphocytes. The B stands for bones. T lymphocytes. The T stands for the thymus. And then we have natural killer cells. B lymphocytes are part of our humoral immunity. Humoral means blood, so it's part of our blood immunity. The B cells, they differentiate. So when we have some type of issue, some type of viral infection, chronic inflammation, or anything else like that going on, and they get stimulated, they differentiate into plasma cells. Those plasma cells then create the antibodies. When they create the specific antibodies for the specific condition, the plasma cells can also turn into memory B cells. That way, if they were ever re-exposed to that specific type of virus or that condition, then we already know what type of antibodies we need to make, and it can do it much quicker. That's why with any type of inflammatory reaction, like allergic reactions, typically the more you're exposed to an allergen in a decent sized dose, enough to create a reaction, the worse each successive exposure gets from an inflammatory standpoint. T lymphocytes, we have T helper cells, also called CD4 cells. These are the cells that are actually going to be activating the B cells to help them turn into plasma cells. T killer cells, aka CD8 cells, aka cytotoxic cells. These are our cancer killing cells. T suppressor cells, aka T regulatory cells. These slow antibody production. They regulate the immune system. Memory T cells, these are the ones that help remember specific antigens, so they constantly are checking for viruses that we've already been exposed to. They're like the history keepers, the record keepers. So we have a faster response upon re-exposure. Natural killer cells, these guys are the hitman of the immune system. Anytime we have a virus infected or a tumor type cell, they find it and they destroy it. Monocytes. Monocytes, these are cells that are circulating in the blood system, in the blood, and their job is to differentiate or change into the macrophages upon entering tissue. They're specifically elevated in chronic conditions because it means we have chronic conditions, we have chronic inflammation, chronically damaged tissues, so they're constantly going. Monocytes turn into macrophages. This is our list of macrophages. This list for sure, 1000%, you always get a question about which of the following is the macrophage in this specific tissue, or let's say, or something along the lines of, the dust cells are activated. The dust cells are shown to be activated on whatever test. Where is the pathology located? Dust cells are for the lungs, so something along those lines. Eosinophils, these are for our parasitic infection as well as allergies. That's the main test you're going to get. So anytime that you see eosinophils are raised, we are either considering a parasite or there was some type of allergic reaction happening. Basophils are kind of the last type of white blood cell. We don't ever really talk about them. The only other thing that we can mention is they release histamine and heparin, so they're also involved in allergies, but very rarely do we get asked about basophils. Mast cells, these are also involved in our allergic reactions and anaphylaxis. They're activated by IgE binding. So immunoglobulin E binds to mast cells. Immunoglobulin E, these are activated when we have some type of allergic reaction. They bind to mast cells to produce all of this other stuff. Cytokines, don't worry too much about the specific cytokines. There's a bunch of them, and honestly, it's not worth our time to memorize every single one of them. We want to know the abbreviations, though. IL is interleukin, TNF, tumor necrosis factor, IFN, interferon. I'm going to skip through a couple of these and just point out the most important thing. Bradykinin does vasodilation. Histamine does vasodilation, but also bronchoconstriction. A lot of people get that mixed up, so don't be one of those people. Prostaglandins, they're responsible for fever. Substance P, this is what transmits our pain signals. More recently they'd like to ask questions about substance P, specifically like what is its functions. Enkephalins and endorphins inhibit pain sensation. NSAIDs inhibit the COX or the cyclooxygenase enzymes. Steroids, they inhibit phospholipase A2 and cytokine production. Phospholipase A2 is one of the enzymes that is involved in actually clipping some of the phospholipids that give us arachidonic acid. Arachidonic acid is the parent of all of our different a lot of our different inflammatory mediators. So our thromboxanes, our prostaglandins, our prostacyclins, our lipoxins, all bunch of our inflammatory stuff stems from arachidonic acid, which is one of our essential fats. So inhibiting phospholipase A2 inhibits the release of arachidonic acid, which therefore inhibits a lot of our inflammatory response. Okay, this one was a little bit longer than I would have liked, but a lot of good information in here. So that is our inflammatory process and a bunch of our inflammatory mediators. We'll continue on with the next one. Probably the next couple of videos we'll be talking about cancers and neoplasia.